Dr. Heidi Peterson. Here is the woman you guys need to talk to if you have SIBO, if you have SIFO, as in if you have a fungal overgrowth or even suspect it. I have the pleasure of sharing some time with her right now and with you. Now, is she taking new patients? That's going to be your question. And the answer is sort of. She does take new patients by application, meaning that she wants to make sure you're the right fit for her because she doesn't want to waste your time and she's really busy. So if you want to work with her, then go ahead and reach out to her website. You can send in a little note with your 3 or 4 sentences about your situation, and Audra at her office will get back to you, and then they will figure out, along with your response, as to whether or not it's going to be a right fit and whether or not she can fit you in. That's the story. She is a naturopathic physician. She is in Oregon. This has been almost a year in the making, by the way, to finally have this chat. So I'm very excited. Hello, Dr. Peterson.
Hello.
Hello, hello. So you come very highly recommended, as everyone does on the summit, from Dr. Allison Seebecker, and she wanted me to talk to you about my yeast situation along with SIBO. So let's educate everybody and ask a very burning question. If you have yeast and SIBO, do you see that all the time? What should we do about it? What are your first thoughts when someone comes to you and it looks like, is it SIBO? Is it Candida? Is it both?
Right. Well, one thing I want to give a little history here. I've been in practice a few years longer than Allison. I'm now one of the older doctors out there. And what's interesting to me is when I was first in practice and we were getting this sort of what I would call SIBO-like symptoms, the bloating, the constipation, diarrhea, good 75–80% of the time I was treating for Candida overgrowth. Now, flash forward 20 years later, and I'm still treating for Candida, but I'm also treating a lot of SIBO. And I don't think it's just that we now know how to diagnose SIBO. I think that there has been a kind of shift in the microbial dysbiosis, if you will, towards sort of a more complicated, disrupted ecosystem. And, the one thing that I will have to say is, I love treating yeast overgrowth, and if I were personally going to choose between Candida overgrowth or fungal overgrowth and bacterial overgrowth, oh my goodness, I would choose fungal. It is so much easier to treat than the bacteria. So I think that's the good news. And I think what we're finding when I chat with my colleagues who treat SIBO, and Allison, I think others agree, is that often the bacterial growth isn't the only problem, right? So you often have parasites, you often have yeast, as well as many other issues. And it's kind of like figuring out who is the primary player. But, treating the yeast, I think is hugely, hugely helpful and has been the barrier for many patients. And I think if you've sort of been stuck and you've only been treating for SIBO and you haven't been evaluated for yeast, then if you've been treated several times and you haven't, you really should look into that.
So do you have a test that you normally do for Candida?
Well, I run about 3 or 4 different ones. So sometimes, depending on the lab, the Candida will be reported on an O&P. Some labs do, sometimes don't. Some labs will do a stool culture for Candida, and that's another option. And then a third option is you can do a blood draw for Candida antibodies. Now that's a little bit tricky to interpret because, the elevated antibodies can mean current or past infection, and it doesn't really necessarily say where they are in the body, but, that is another way to evaluate it. In my tougher cases, I like to use a lab that both does the Candida culture and shows also on the O&P or the microscopic exam. And the reason I like to do both of those is I feel like that's a way to differentiate where in the gut the Candida is growing. So if I see it on the culture, that means that the yeast is in the large intestines because it's actually alive when it's coming out, or it won't grow in the culture. Many times, particularly with SIBO type patients, what I'll see, the Candida culture will be negative, but when they look in the microscope, they'll say many yeast bodies. So what that means is that the yeast is actually dead when it's coming out because it's not growing on, you're putting the the yeast body is on its favorite food and it's not growing. But when they actually look on the microscope, there's a ton of dead yeast bodies. And that to me says, yes, it's farther up in the, in the digestive tract and more likely in the small intestine.
So when you're saying, are you saying OMP?
Oven parasite, which is sort of, which is sort of the standard microscopic way that they look for parasites. But depending on your lab, and it's not every lab, but if you've got a better lab, they're going to report when they see yeast bodies in that exam. But not every lab will do that. So just if you've had an oven parasite exam and it hasn't shown yeast, they may actually be there, but your lab may not have reported them.
So, okay, so let's just recap that, because you can do a stool test for it. And
so there's two stool tests. One is a stool culture, right? Where they put the stool on a medium that yeast like to grow and they look for them to grow. But that depends that the yeast organism is actually alive in the stool when it's there. And I think that I only see that really culture when it's in the large intestine. I think it's too far up. If it's in the small intestine, they're dead by the time they come out. So then if they're in the small intestine and you culture it, they're not going to grow out, and you're going to steal it on a stool test, which is called an ovum parasite, which is just really the microbiologist looking in the microscope and seeing and noting that there's yeast bodies there. The tricky thing is that test is sold as a parasite test. So depending on the microbiologist, sometimes they're like, well, I'm just looking for parasites, so I'm only going to report parasites, and then I'm not going to bother to mention that the whole screen is covered in yeast bodies. That's sort of what I think about. I have no idea what the lab rules are, but I've noticed that from different labs. And then the third option is a blood test for Candida antibodies. That's actually pretty easy. Quest, LabCorp, most of your major labs will do it. It's just a little trickier to interpret exactly what that means.
And which is your preferred one? Or are you saying we should probably try to do at least two? Because
my preferred is I work with a lab that will do the microscopic test and show the bodies, and we'll do the culture. And I prefer that because that gives me a sense, is this in the large intestine? Is this in the small intestine? And, I think that's in treating SIBO, that's always kind of the tricky question is, where in the digestive tract is the problem? Is it a large intestine problem? Is it a small intestine problem? And in fact, I've had many patients come to me for SIBO where actually the problem wasn't in the small intestine, it was in the large intestine. And many of the treatments are the same, but I think it's helpful to know where you're treating.
When you're saying that they've come to you for SIBO and you found that the problem was in the large intestine, are you saying that they came to you for SIBO and it turned out that they had a fungal overgrowth and it was in the large intestine?
Or bacterial overgrowth in the large intestine too. So I don't know if you've talked about this with other providers, that they, you can have bacterial overgrowth in the small intestine, but you can also have, well, I don't know if bacterial overgrowth is really the right term, because of course we have bacteria in the large intestine. I use the analogy weeds in the garden, that you have an overgrowth of certain types of bacteria in the large intestine that maybe would be okay there in small amounts, but in large amounts are not healthy.
And how do you test for that if it's in the large intestine and you're trying to figure out, which weeds are there and overgrowing?
I do a bacterial stool culture. So you can do a fungal stool culture or a bacterial stool culture.
Okay. In this summit, what we are doing also is we're encouraging everyone to actually name labs. So
okay, that's fine. That's fine. I didn't know, I'm being cautious because sometimes they in certain things they don't want. So I'm old time. I like Diagnostics Lab. I think it's only through providers, I believe. It's out of Washington. It has its pros and cons. All I have to say is I've used them for over 20 years, and I feel like I really know how to read that lab well. They have a great website. I will tell you, one of the reasons I've continued to use them, they are perhaps the cheapest lab out there. Doesn't mean that they're the worst. I think they're cheap. They haven't changed their graphics in 20 years, but they, like I said, they have good information. And I'm sure as you've talked, every providers have their favorite labs, but I think particularly for the fungal issue, they're good because they will do the bacterial stool culture, the fungal stool culture. and they will report on the microscopic exam whether they see the yeast there or not.
Okay. So what are some, let's say someone's watching this and they're like, I've never even thought about whether or not I had a yeast overgrowth in my small or large intestine. I just thought I had SIBO, or I just thought I had, some dysbiosis or motility issues. What are some symptoms that someone listening to this should probably think about as being expanded perspective about whether or not this is something that they should pursue? What are some of those symptoms for those overgrowths?
So some of the symptoms are really same, right? You got your classic IBS, you got your bloating, your diarrhea. But I think the thing that's really interesting to me when I compare sort of SIBO and the fungal overgrowth, that some of the foods that are often tolerated by SIBO patients, so like you're thinking about like your white rice or even simple sugar, which is it's always amazing to me that, it's always frustrating to me with SIBO that like the healthiest foods are the ones that make the patients the worst, and that kind of white junk food is actually that makes them better. But with the fungal overgrowth, those foods actually tend to make people worse. So either you're going to see a picture, the classic Candida picture is they can't eat sugar, they can't eat white rice, they can't eat really dried fruit juices, things like that. And they actually do well with the high fiber foods. I think when you've got SIBO and an overgrowth of fungus at the same time, you're in that situation where like, okay, they really can't eat anything because they can't eat any of the high fiber foods that bother SIBO people, nor can they eat any of the simple sugars or fruits that actually should be okay for a SIBO patient.
Go ahead.
A couple other things is I think if people have SIBO issues, they tend to be fungusy all over. So they may have athlete's foot, they may have, yeast overgrowth under the bra line happens in women, obviously in women, vaginal yeast, or they may have associated, I see a lot of unknown skin rashes where people get these sort of dermatitis that sort of are all over their body, and they've been to several dermatologists and nobody really knows what they are, and they're traveling around. I've also seen that associated with fungus.
So that's if you have, that isn't so much a primary illustration of SIBO, but it is of Candida.
Of Candida. I mean, I don't know about your opinion, but my opinion, I don't really see SIBO causing I see SIBO causing like rosacea and those kind of skin problems, but like an itchy kind of eczema, random rash that is sort of traveling around the body, I don't really see that with SIBO.
And that's not to be confused with psoriasis, right?
No, I'm not talking psoriasis. And these are when I've treated people for these kind of rashes, they've been to the dermatologist, and the dermatologist is either calling it eczema or dermatitis, and they're like, I don't know, when they're saying put steroids on it, right? Okay. So, yeah. It's sort of an undiagnosed sort of itchy rash, itchy scaly rash, but not like psoriasis at all. Although actually I will put on a side note, psoriasis is highly associated with Candida overgrowth.
Really?
Yes, very. But that's a separate story.
Yeah.
But,
well,
yeah.
Well, actually I do want to just touch on that for a second, because I've always thought of psoriasis as an autoimmune disorder.
Well, right.
But so how does Candida and autoimmune interact?
Well, sort of the same way that bacteria and autoimmune, as a naturopath, when we're approaching autoimmune disease, we're really looking for dysbiosis as a trigger, right? So with the idea that your immune system is reacting to fungus or Candida, is reacting to a parasite, is reacting to bacteria, and in making those antibodies, it's those antibodies are then attacking other parts of your body. I think that's going on with SIBO, but that can happen with Candida overgrowth, and I think it can happen with parasite overgrowth as well.
How many of the percentage of people that you see that do have SIBO and that do have Candida or whatever, I'm just saying how prevalent do you really think parasites are? Because I think in this country there is a shame associated with it. There is denial about it. And then if you have it, all of a sudden it becomes very normal. And like, why isn't everyone else talking about this?
Right.
It's so common.
I've been treating parasites again for 20 years. I think they're out there. And, I think basically American doctors aren't trained to diagnose and treat them and aren't looking for them. Our labs are not doing the right testing. I've been using, Para Wellness Lab, and, that guy is really great at parasites. And, I joke with my patients, you worm your dog every year. Now we're not out there, sniffing the yard and eating cat poop, but we live on this planet, they live on this planet. If you have a weakened digestive system, you're going to get them. I mean, you know, I had a patient that ate at a food cart and got it. I mean, it's not, I'm not saying you shouldn't eat at food carts, but you know, it's going to happen. And they're really out there way more than most doctors want to think about. Or, you know, the other comment that I've seen is people have been diagnosed with parasites, and the CDC will use this term commensal, which means that they maybe don't belong in the gut, but they aren't harmful. And I kind of beg to differ. I think particularly with people with compromised immune system or compromised digestive system, that there are people where, you know, like Blastocystis hominis really is causing a problem. And then I think there's other people that it's not. I think that's also true of yeast. You know, I've heard medical doctors complain and be like, oh, yeast is normal in the gut. And I think in a really healthy digestive system, some people are going to tolerate yeast in their system and other people aren't going to tolerate yeast in their system. But for people, when the immune system and the digestive system is compromised, I think it's a huge problem. One other comment on that, I just to kind of extend that example a little further, I do think that I have some people that develop what I call a yeast allergy or yeast hypersensitivity. That's when I find that blood test really helpful. And in those people, they have zero tolerance for yeast in their gut because their immune system is reacting to it. And they really are, you know, in one little yeast body in there is going to trigger a huge amount of inflammation. And so, you know, I think that's some of the way that we get the difference is that some people are quote unquote allergic to yeast, and that they have a lower tolerance for any yeast in the digestive tract. And that's where that blood test if those antibody levels are really high, then I am more suspicious that there is this sort of yeast allergy going on, and that we have to be super aggressive in treating to get the yeast entirely out of the system. Whereas if somebody didn't have that yeast allergy, they might tolerate a little yeast. Does that make sense?
Yeah, no, it totally makes sense. One thing I also wanted to ask you about was you said earlier that yeast could be, if you have diarrhea, it could be a sign of yeast.
Yes.
Is that also true for constipation?
Oh, absolutely. It goes both ways. It's just how the body wants to respond.
Okay. And then I've heard about systemic yeast infections or Candida overgrowth. Is that possible in places other than the vaginal area, the mouth with thrush and the gut? Does it go elsewhere in your body also?
Well, I think we have to be really careful with that term systemic, and I try to avoid it at all costs, because in the MD world, systemic Candida means that you have a Candida, like basically Candida sepsis, right? The Candida is growing in your blood. And that is not at all what I'm talking about. I mean, that does occur with like HIV and really sick patients, and that is a huge medical emergency. I really just think of it as like, is that dysbiosis Candida overgrowth. So you can have yeast overgrowth, right? Our fungus overgrowth on your skin, and that's like ringworm or athlete's foot. You can have Candida overgrowth in the vagina. I've seen it, by the way. Sometimes it overgrows in the bladder, so that women that have irritated bladders can have it there. I have a lot of patients that overgrows in their ear canal. I mean, I guess that's really the skin, but I've seen it there. Of course, thrush in the mouth. I just treated a patient this week that had it overgrow in her mouth. But I think we're really looking, you know, when I'm kind of, you know, if I sort of think of the body, there's sort of the outside and the inside. But I think of your digestive system as still sort of outside of you, right? So if you think of your digestive system, it's just a big tube running through you, starting through your sinuses and going out, but it still is sort of outside your body, even though it's inside of you. That reminds me, of course, a huge area that I treat for fungal overgrowth is the sinuses. And actually that can be quite tricky, because if you have fungal overgrowth in the sinuses and you're just treating the gut, you can never get on top of it, because where do your sinuses drain? But into your gut. So if you're constantly having, if you have fungus overgrowth in the sinuses and it's constantly having postnasal drip in the gut, if you're just taking something to treat the gut, you're never going to get to the core of the problem.
And what would be one of the symptoms for the sinus overgrowth?
Chronic sinusitis. I mean, there was one study done, and this is a quite old one, 1999 Mayo Clinic, where they irrigated people's sinuses and they got the fungus to grow out. And it was really interesting because normally if you do that kind of swabbing, you won't get fungus to grow out. And they put a special agent in there that broke up the mucus. And when they did that, I think I don't get the numbers exactly right, but it was over 90% of people with chronic sinusitis actually had fungus in their sinuses. So it's pretty prevalent. So if you are, if you struggle with sinusitis, and maybe you have SIBO and, some of these other things, it might be worth looking into that as a problem.
And how would we go find out if it wasn't our sinuses? Is there a test for that?
I wish. I haven't found, the Mayo Lab did this great test in 1999. That one is not that was a research study. I have not found a test that's really worked for it. Basically, what I do with my patients is maybe we've tested on some stool testing. We think there's yeast in other places. They have some symptoms. And then I do a trial of antifungal treatment in the sinuses. And, if they get better, then they get better, which is not my preference. I actually have a master's in chemistry. I'm trained as a scientist and I really love tests and I love data. But there, there aren't great options for that, which I keep looking for.
Okay, got it. Okay, so you figure out if you have it, you think you may have it, or now you're realizing, hey, that might be a problem for me. Then you get some sort of conclusion. At worst case scenario, it's just anecdotal. Now what do you do? What should we do? Do we all have to give up all of our sugar and all of our starches?
Oh, no. And I have to say, I apologize. I'm going to get on a soapbox here. I do feel like we can get in what I call the ever disappearing diet. And, I will meet people that are eating literally like 5 foods. And that has never been my goal for people. And although I'm a naturopath and I really like treating people naturally, I think that there's this tendency that people want to treat by diet alone. And they're like, well, if I can just get my diet right, I'll get better. If I can just get my diet right, I'll get better. And I just don't think that's true. So the analogy I like to make is your garden. And if you have weeds in your garden, and you throw some mulch over the weed, or maybe you plant some plants, you might not have as many weeds, but the weeds are still there and they're going to grow back. So my approach is you got to go and pull the weeds first, and then you plant the healthy plants. So when I'm treating people for Candida growth, I'm treating them with antifungals. So that could be herbal antifungals, and there are a lot of those, and those can be nice because they can overlap with some of the same herbs that'll treat SIBO. So you can get a twofer for that. And then sometimes I will treat people with pharmaceuticals for Candida. And, I hate to say this, but it is, I think after 20 years of treating it, it's true. The herbal treatment actually ends up being a little bit harsher. That there's a phenomenon with the herbs called die-off, where you start killing the yeast bodies and they break down in your body and they release all these chemicals, and it triggers what's called a cytokine storm. And essentially you feel like you have the flu, which in some ways is not bad. If my patients call me up, I'm like, well, yeah, then I think you had some yeast there. Like it is confirmatory, but it's pretty miserable. I've had people in bed for 3 days. Oddly enough, when I use some of the more pharmaceutical antifungal agents, there isn't as bad die-off, which I'm not entirely certain why, but there is some research that those agents are a little anti-inflammatory as well. So I think the die-off is occurring. They're killing the fungus, but people feel maybe don't quite feel as bad. And again, with the herbs, you're often doing oral agents or intravaginal, intranasal. With the pharmaceuticals, you're actually getting systemic. So sometimes they can get to some kind of deeper layers that the herbs can't. So, in my practice, I'm open to all agents, and I want to use the safest and the easiest thing for people first. But sometimes, and I find this with parasites too, sometimes the prescription agents are just as gentle as the herbs, or I think sometimes it's a mistake to think that the herbs are going to be less harsh than the drugs, if that makes sense.
It does make sense. It does. When it comes to the pharmaceuticals for the antifungals, do you have a preference? Obviously, it's going to depend on the patient and all that, but are you a fan of Diflucan? Some people are short-term, some people are long-term with that. Some people are very concerned about your liver enzyme levels for that. What's your thought on Diflucan?
I mean, I think Diflucan is a good starting point. It's inexpensive. It's available. I've had it work for people. I do think you need to worry about the liver, but I don't think you need to worry about the liver unless you're taking month on, month on. So I might treat people for 2 to 4 weeks, and I'm not really worried about that. I generally recommend some sort of herbal liver support or NAC, or, you know, do something to support the liver. But I really haven't had a problem with that one. Occasionally I'll go, there's ketoconazole, itraconazole. They're sort of stronger cousins of Diflucan. And I will, you know, go to those. There's some older drugs like amphotericin B. Gosh, a patient of mine, I just consulted another doctor, recommended that. I'm a little afraid of that drug, and I don't do that one. But I think Diflucan is great, and I've seen it help people. In fact, my kind of concern is that I feel like if people have been treated with it, they've maybe been treated not long enough. So I've seen people have like a 1 to 3 day course. And what I'm seeing in my practice is that people are needing sort of 2 to 4 weeks. So, but you know, people usually feel better pretty quickly on it. I mean, it's one thing where like usually I think what happens is within the first few days, we're getting rid of the yeast, we're getting rid of the candida, and people actually feel better. And the reason I'm treating longer is to allow an ecosystem to evolve in a mold-free, in a candida-free environment that's stable. And that I find that if people just treat till symptomatically they're better, then we're 3 or 4 months back treating the same thing again.
Right. And are you doing the Diflucan, and it's also called fluconazolone? Is that right?
Yeah, fluconazole.
Okay. Fluconazole. Okay.
Yeah.
And are you doing it twice a day if someone seems to have a heavy load, or is it just once a day? What's your typical milligrams? Obviously, no one can just like go out to CVS and get that.
Yeah, I mean, I'm doing 200 milligrams once a day. I don't really see, you know, if you look at the pharmacology of the drug, I don't see the need to do more. Now, if I do nystatin, which is another prescription agent, and that's, I think of that as sort of natural, it's made by fermentation. I'll do that 3 or 4 times a day. And I also will do the herbs 3 or 4 times a day. But a typical protocol I might do is 2 to 4 weeks, once a day of Diflucan, and then transition people to sort of a maintenance dose of either nystatin or herbs. And, you know, depending on how much fungus is there, sometimes you need to do some sort of antifungal agent, probably herbal, 3, 6, 9 months, or even a year of doing something antifungal to allow the gut ecosystem to evolve and sort of come to some sort of equilibrium and not allow the yeast to grow back.
And the big question then is, what are the herbs that you're typically talking about with your patients? And then this diet thing again. So for me, long-term yeast patients, since I was like in junior high school, remembering those first, you know, yeast scenarios, like, what's that diet component? I just want to circle back when you're doing the herbals or the pharmaceuticals.
So I'll mention a few herbs, but I will say I have a page of herbs. Like I have a whole page of herbs that I use with different people. But uva ursi is a nice one. That's one that a lot of people don't know. Berberine, you know, works well, but I do find, you know, a lot of my SIBO patients, a lot of people maxing out on berberine where they, and I think berberine is not, I see it cause a lot of diarrhea in my patients, which if somebody's constipated, I might like, but if they have diarrhea, I don't really like. Then I will often use, ITI has a Paragard product, which is a parasite product, but it actually works really great. I often will use oregano oil. Sometimes I will do Colorex. I don't know if you know Colorex. I can't remember the herb it's in it. It's from Australia. That's another nice one. Sometimes I'll use monolaurin or lauricidin. And usually with the herbs, I'm rotating people through. You know, we'll do a bottle of something, then we'll do a bottle of something else, and then we'll, you know, move on there. With the diet, I am not as strict. I mean, I guess this is where I kind of come back to liking the Diflucan, because I think if you are like using something Diflucan and then graduating to herbs and you're really treating for, you know, six months to a year, I don't think you have to be as strict on the diet. Do I want anybody eating tons of sugar? No, I'm pretty no. And I'm like, have some fruit, but let's have like 1 serving a day. Like, let's not be a fruitarian. You know, I'm wanting more. Do I really want white rice? No, I'm preferring brown rice. But of course, if I'm working with somebody that has a comorbidity of SIBO, then we're kind of dancing that line a little bit. But I think you have to, because I think some of these diets that I see my patients come in are just ridiculous. Like I just don't think they're sustainable. And I've become really concerned in a lot of my patients that they've gotten too low on carbohydrates. I mean, I will tell you a case. I was just doing random blood work for a patient, and I drew her blood sugar, and her blood sugar was like 55 in the morning, which is way too low. And I called her up and I'm like, what are you doing? And she had just gotten too low carb in her diet. And then we just added back some healthy carbs, and guess what? She started sleeping through the night, and her depression and anxiety went away. So I do think that, it's kind of funny. I grew up in the 90s, and I remember, in the 90s, everybody was like big plates of pasta and carb was queen, and we didn't want any fats. And now we're kind of gone the other way, and it's like, okay, lots of fat and no carb. And I've done the ketogenic diet and I'm a fan, but I also think that's not a long-term thing. And I think for long-term living, people do need some carbs. And I don't know if you've run into that with your working with SIBO, but I think people are getting too low carb and don't feel good on it.
Right. Yeah, that's very consistent. But and there's a lot of experimentation going on too, thank goodness. And the kind of more experimentation, the better, because it'll probably be what I call spinning your plate. Like you'll get more variety, at least if you're still like experimenting.
Right. Yeah. Yeah.
Hopefully you find something that works for you, short-term or long-term.
Right. One other thing that I want to get in, and this is a whole other world, but I just want to get this word out to people because it's really a passion of mine. One of the things to consider if you have a chronic Candida function, so some of your listeners maybe haven't even looked into that and look into it, and other people might be like, yeah, I've been treating Candida for 20 years or 10 years and not been successful. One thing that I treat a lot in my practice is exposed to toxic molds. So having toxic mold in your house is not necessarily the same thing as having Candida in your gut. But here's what I know is if you have a mold overgrowth in your house, so you have a leaky roof and there's mold in your attic, or your bathroom leaked and there's mold in your subfloor, lots of different mold issues like that, that you will never, ever get over those mold Candida issue in your gut when you still have a mold or mycotoxin exposure in your environment.
So I know you have to go, but I just want to ask you one thing. Is there a test to do to see if there's mold in your environment that you've found to be effective?
Yes, there's several. Basically, you can buy these little sort of online little sort of agar plates. That's a very rudimentary. Often in my practice, I'm hiring specific mold inspectors to come in and do it. Like it's not the same as a home inspector. And in fact, I learned recently that home inspectors are not actually allowed to, at least in Oregon, allowed to say when they see mold, some weird legal thing. But they're actually mold inspectors that can come in, and those for the sickest people, that's what I'm looking at. I'll share with you. Do you have a place to share documents with people?
Sure. Yeah.
I have a little handout I'll share with you that sort of is mold the cause of your symptoms, and it has sort of symptoms to look for and things to look for in your house, and that's sort of a good starting place. But usually I'm having my patients hire a mold inspector to come in. But that, I just want to get that word out, because I have had people sick for years, and that was really what was driving it. Unfortunately, it's an expensive cure because it often means either moving or remediating the house. But if that's what it takes to get well, that's what it takes.
And so even though that mold is a different kind of spore than the Candida, you see
Correct.
them sort of interacting.
Well, because they it causes immunosuppression, and it's sort of it's very, very common when people have the mycotoxins exposure in their environment that they have Candida overgrowth in their gut. It's not the same thing, but there's a huge relationship.
Dr. Peterson, thank you so much.
Thank you. I hope this has been helpful, and I maybe can come back another time.
Yes, definitely. I'm glad you said that, because we have another summit coming.
All right. Take care. Have a good day.
Thanks, you too.